Today, we are going to break down an absolutely critical nursing skill, the systematic cardiovascular assessment. And look, this isn't just about ticking boxes or documenting vitals. This is about learning how to see a crisis before it happens so you can be a true guardian of your patient's stability.
You know, it really all boils down to this one simple, powerful equation. Perfusion is life. It's the whole game. Getting oxygenated blood to the tissues is what keeps us all going, and that's why this statement carries so much weight. Because think about it, oxygen is useless if it doesn't have a delivery system. So the whole point of this assessment is to answer one critical question. Are the tissues actually getting what they need to survive?
And that, right there, is the biggest challenge. Hemodynamic instability, that breakdown in perfusion, can be a silent, creeping crisis. A patient can be going downhill long before a single alarm starts beeping. So how do you see the invisible? How do you catch that subtle decline right at the very beginning? Well, we're going to tackle that exact question with a clear game plan. First, we'll talk about the silent threat. Then, we'll lay out the 5-point assessment framework. After that, we'll get into interpreting the patterns, apply it to some high-stakes scenarios, and finally, we'll talk about your role as the hemodynamic sentinel.
So let's start with this fundamental problem. A patient can look totally stable on the outside, maybe even have a blood pressure that looks fine, while their body is silently fighting an unfolding crisis. It's like they're putting up a brave front, and this is where early detection becomes your primary, life-saving duty. Let's just let this one really sink in for a second. You can have a patient with a perfect oxygen saturation, 100% on the monitor, but if their circulatory system isn't actually delivering that oxygen to the brain, to the kidneys, to the heart, that number means absolutely nothing. Your cardiovascular assessment is the tool you use to confirm that the delivery truck is actually running.
So, how do we get this right every single time? We have to move away from just random checks and toward a structured, repeatable method. So let's break down the 5-point toolkit that will help you leave nothing to chance.
And here it is, your 5-step protocol. It's so logical. We start at the source with the pulse. Then we look at the pressure in the system with the blood pressure. Next, we check the endpoints, what's happening out in the periphery with capillary refill. Then we assess the volume in the tank with fluid status, and finally, we check our own work with IV therapy safety. See how each step builds on the last? It creates a complete clinical picture.
All right, let's dive into step 1, the pulse. We are not just counting beats here, we're feeling for its character. Is it weak and thready? That could be a sign of low blood volume or maybe even early shock. What if it's bounding and forceful? That might point to something like a fever or sepsis. And is it the same on both sides? These little details are your very first clues.
Okay, next, blood pressure. And this is a huge one, so listen up. That normal number on the monitor can be a total trap. It can give you a false sense of security, because the body is brilliant at compensating. It'll clamp down blood vessels to keep that pressure up, even when the tank is running low. So a normal BP doesn't mean stable. It often means the patient is working incredibly hard just to look stable. Your interpretation here is everything.
And this brings us right to step 3, where we can literally see that compensation happening. It's called peripheral vasoconstriction. Basically, the body is smart. It starts shunning blood away from the skin and toward the vital organs at the core. And we can spot this. We see it through cool skin, maybe some paleness, and a capillary refill that takes longer than 3 seconds. These are your first real, tangible warning signs that the body's in trouble.
Now, steps 4 and 5 are all about fluid balance. And as you can see here, it's a real tightrope walk. Too little fluid, and you compromise blood volume. Too much, and you can overload the heart. Either way, perfusion takes a hit. And this also means checking our own interventions, right? Making sure the IV is actually running, the fluid is correct, and it's going in at the right rate.
Okay, so we've collected all our data. We have all our puzzle pieces. Now for the most important part, using our clinical judgment. This is where we stop looking at numbers in isolation and start connecting the dots to see the real story that's unfolding.
Let's build a pattern together, okay? So first clue, you notice your patient is tachycardic. Their heart rate is up. By itself, that can mean a lot of things, right?
But then you feel their skin, and it's cool to the touch. Okay, now you're seeing a pattern emerge. A fast heart rate plus that vasoconstriction we talked about. The picture is getting clearer.
And finally, you check their capillary refill. And yeah, it's sluggish, maybe 4 seconds. Now you don't just have 3 random data points. You have a clear, distinct pattern.
And you know what? That pattern has a name: early hypovolemic shock.
It's a state where blood volume is dropping, leading to poor oxygen delivery. And you saw it, not because an alarm went off, but because you interpreted a pattern of subtle clues. That is the power of a systematic assessment.
And this slide just perfectly highlights the two different ways of thinking about this. You have the data recorder, who just sees numbers, heart rate 110, BP 100/60. Done. But then you have the clinical interpreter. They see a pattern, and they start asking the critical question, wait a minute, is this compensated shock? One person sees numbers, the other sees potential disaster.
So, where does this skill matter the most? Let's talk about the high-stakes scenarios where this kind of systematic assessment isn't just good practice. It is absolutely 100% non-negotiable for patient safety.
In any of these patient groups, the risk of going downhill fast is incredibly high. Post-op patients, they could be bleeding internally. Sepsis, that can cause the whole system to go haywire. Heart failure patients are walking a fluid-balanced knife edge. In these situations, your systematic assessment is the safety net that can prevent a patient from spiraling into full-blown, decompensated shock.
And this all brings us to our final and I think most important section. This is about reframing your role. You are not just there to do tasks. When you perform this assessment, you are acting as a hemodynamic sentinel. You are the vigilant guardian of your patient's stability.
This quote says it all. Your goal is not to just fill out a chart. Your goal is to proactively spot that perfusion problem before it leads to an ICU transfer, a code blue, or even a preventable death. This is what real, active patient safety looks like.
So if you remember one single thing from our time together today, please make it this. A stable blood pressure does not equal stable perfusion. You have to always look deeper.
And to do that, to really see what's going on, your assessment has to be these four things. It's got to be systematic, so you don't miss anything. It has to be trend-based, so you're looking at changes over time. It has to be focused on pattern recognition, connecting all those dots. And most importantly, it has to be interpreted with your clinical judgment.
So, I'll leave you with this question, which is really a call to action. It's not about if this assessment will be done, but by whom. It's a responsibility that literally transforms patient outcomes and defines what excellent care really is. So, who's going to be the hemodynamic sentinel on your next shift?